So we are here obviously to share a little bit. We want to have a light and nice conversation. We have Prof Mulier and Prof Amorim here. We will have a discussion between the two, sharing some experience and so on. And I just give the word to Pedro, and then we will
I just
start.
want to break the ice before we start, and it was very unfortunate what happened with Dennis. Fortunately, we'll recover well. But let me share you a little story to break the ice. There was a very famous tennis player, American, Arthur Ashe. Does anybody remember him? So
Yeah.
he was very, very famous. And he was one of the first famous people to get AIDS. That was due because he was submitted to cardiac surgery with blood transfusions, and he caught AIDS and he got very ill. And he decided to make a huge donation to a hospital in New York. I was working at that hospital at the time in Brooklyn because he was originally from Brooklyn, and in Brooklyn AIDS was terrible at the time. So he came to the hospital for a ceremony to give the check, the money. And the hospital had a huge space, and there were probably more than 2,000 people in the room, and most in white coats, nurses and doctors. And when he stood up to the podium, he was already very sick, very frail. He had trouble climbing those 2 stairs. He had to make an effort to speak, and he said, "Well, let me start by telling you that I am so sick that I could die during my speech. And before I start, I want to tell you something very important. If I fall down on the floor, only that doctor and that nurse are allowed to come here and help me. Everybody else remains seated." Big laugh, big applause. And of course he didn't die. Dennis is recovering as well. And we got all scared for a while, and probably he was at risk by having so many people on top of him. And there was someone who he actually applied mouth-to-mouth ventilation today, and I think that he deserves an applause. The hero of the night.
Yeah.
Thank you. We were really fortunate because we have you all, and you help our friend, our colleague, and you make us being a little bit more relaxed. You enhance somehow, or you prevent that we're sympathetic, and the sympathetic of our CEO Fabian Pañe really explodes. So thank you very much for that. But today we are here as well to talk about surgical stress. How in the past, and this is why this session is called Back to the Future, because at the beginning surgeons want you to take care of their patients that they were submitted to a high surgical stress. So today we're going to talk through different unknown stories and very interesting stories about how surgical stress was seen, measured, and treated. And at the very beginning, I've heard a lot of times that anesthesia is an art, and it was seen as an art because obviously it needs a lot of experience for your side and a lot of personal experience treating them in this way or that other way. I've seen that as well, relationship anesthesia with cooking, a cooker, a chef, that is, he just knows how to do the things. I will just tell you a personal story. I had an aunt who was the cooker of a very famous colonel in Spain. So and she did excellent food. So my mom, she wanted to learn from her how he did it, and she phoned her. So how much shall you do it? And she just said, you just see it. No? The same thing that Prof McIntosh, when he was asked, because they wanted to develop the first vaporizer, he was asked, so how much drug should I deliver? And said, just enough to do the job, right? So from there we just passed into new lab techniques. We were able to assess the amount of drug that we were seeing and seeing how much plasma concentration we had, right? That helped us to move from art a little bit more to science. We were developing the pharmacokinetic models that Pablo Sepulveda and others here, Stefan Srag, etc., are expert, and they can discuss if Minto or not is right or whatever. But for sure, we move as well into measuring, right? At first, we were just looking at heart rate and blood pressure. Gettle already started to talk about the stages of anesthesia through the signs of what? The autonomic nervous system response, right? And then we got the BIS monitor at the beginning. Other monitors came to help us in that way. And today we've got, at the very end, the heart rate variability, which help us to assess autonomic nervous system, right? So we have had always this conflict that we are representing in this image from Copernico and the Pope, right? So Copernico was saying what? That it was not the sun who was moving around the Earth. But obviously that was not very good for the Pope, who wanted to be the center of the Earth. And this is something that Protagoras, already a Greek philosopher, says before Christ, saying the man is the center of everything, right? So that was why the sun was moving. So that's why we put that image. It's always the fight between science and beliefs. And we need to transform our beliefs into science, if that's possible. So in that way, I want you to read just the last sentence from Jevons. We said, science teaches us to know, and art teaches us how to do it, right? So without any more delay, I will just give the word to Prof. Mulier and Prof. Amorim, and I will be just the sir who will pass the slides.
Yeah.
Thank you very much.
Okay. Thank you, Nacho, for this nice introduction and to making this event possible, because it wouldn't be possible without the support of M. Dolores in this area. And well, let's start off. And I'm going to ask you in the first aspect, why took it so long to accept that the Earth was not flat?
Well, it took centuries for that to change, and that has to do with beliefs, and that has to do to something that is still present in our practice, which is inertia, which is beliefs, which is some fundamentalism also, against whatever challenges the establishment, established ideas, and we hope that now it doesn't take so long to change people's minds, people's practice. And actually the first demonstration that the Earth was not flat was after Magellan sailed around the world. And it's very interesting because Magellan was killed at some point in the Philippines. He didn't finish, but he had sailed several times to India and farther east, and he had captured a slave that he brought with him to Portugal, and the slave accompanied him when they started sailing west. And one day they reached an island where the natives could be understood by the slave. They spoke the same language. That's where the slave came from, and that was the demonstration to Magellan that the Earth was indeed not flat. So let's go to science
and look also why it probably took also very long in our daily practice to adapt several aspects and beliefs and changes into a science. And yeah, and anesthesia, although already 150 years, it's quite young. And,
well, but let's go to our story.
And we have the opportunity today to learn a lot from Jan, who loves narratives and anesthesia. And how did surgeons or barbers at the time manage to keep a patient so that the procedure could be performed? How did they manage that without anesthetics?
Yeah, well, it definitely was with stress. and the
Mostly from the patient.
and maybe the surgeon also had a lot of stress, but what he did was, it were only minor procedures, very short aspect. Even the surgeon, the best surgeon was the surgeon who could do it in the shortest time possible.
How short?
And short, well, even when the ether came up already, the most famous surgeon said it was like, time me. Time me with it, now I start, and like an amputation should be done in 100 seconds.
100 seconds.
100 seconds. And if you could do that, then even the patient's reaction were that short. So that was the first time. The second aspect was they didn't have anesthetics, they had alcohol. So using a lot of alcohol, that was the first approach. Even they were trying to dissolve some plants in this alcohol, also a little bit of opium, and that was then the laudanum, Paracelsus, named after Paracelsus. And so laudanum was an approach by which you could give a little bit of opium, but everyone's really afraid. Even Paracelsus was said, although we said laudanum invented by Paracelsus, is not coming from him. Because he was writing very clearly, you shouldn't use opium because the patient might stop breathing. And so you better use other aspects. Even, and then maybe I'll come forward, he invented the ether already. And made an explanation how he brought chicken under anesthesia. This is
when was that?
1500. 1500. He brought chicken under anesthesia with ether, and was then telling from why shouldn't we use that in humans? Why took it so long, 350 years, before we reinvented that approach? Again, the time is running.
And when anesthesia first started, how was stress managed?
Well, yeah, it was the problem was when anesthesia started, and finally with chloroform and first with ether, it was one drug doing everything. So what we have to do was to go as deep as possible. So to get the patient asleep, to get the patient non-moving, and maybe less stress. But no one was even measuring that. But the big problem was you get hypotension. And that's why chloroform immediately came after the ether, because the chloroform was very nice, but the Americans said we stay with the ether because we have less hypotension. And that's why you also made a mixture between ether and chloroform. But the trouble was you went very deep. And that was the big problem actually at that time. And so probably again stress was dramatic, and again the surgeon had to be very fast, maybe not 100 seconds, but it was in minutes. And that was important.
What was the next step in anesthesia after ether and chloroform?
Well, the next step came actually when they start talking about balanced anesthesia. And we all think about balanced anesthesia and the triangle of Cecil Gray, but it is Lundy from actually who brought that in. And he compared balanced anesthesia, when he took the word, he said, we have a balanced diet. And a balanced diet means we are not eating only meat or only, we took several diets together, we balanced that. So let's do the same with anesthesia.
Which year was that?
And that was, he was the anesthesiologist of the Mayo Brothers in Rochester, 2026. And but balanced anesthesia was when he brought in pentotal. Pentotal followed by ether and chloroform, and that was for him balanced anesthesia.
And where was pentotal invented?
Well, pentotal, actually, A.V. Paul was already a lot earlier invented by the Germans, and they were using already in 1906 A.V. Paul. But because of the First World War, it was broke down, And then the British came out with the Pentotal, that was later in 26. And that was when Lundy said, let's combine that with ether and chloroform. But the nice story is even that Lundy said, look, with the Pentotal we might have even more problems, and it would be ideal to use the Evipol. But the Evipol never has made it, because everyone still remembers the times of the Pentotal. And in the Second World War, the Evipol had really gone away.
At that time, were they giving Pentatol for induction or just as an adjunct to?
Well, even with Lundy, it was giving it continuously in balance with ether chloroform. And so the idea was already, instead of giving a high dose of ether, let's combine. And so he was giving Pentotal at the same time during the inhalation. But as you can see, the stress was really, really not covered. And was still missing at that time.
So this was the beginning of science in anesthesia with Lundy, you would say?
Yeah, absolutely, because Lundy started really as a real practitioner, but he's the one who said, let's go on a scientific approach, and he brought from Rochester. He also said the anesthesiologist should be focusing on science, and then maybe here, we can see it here, the value, he was talking the value of the fundamental science in the assessment of anesthesiology. Let's talk scientifically. So he was really focusing on that, because at that time it was still largely an art, and gradually developing a science. Science teaches us to know, and art teaches us to do. So we really had still that, but he might be one of the pioneers in that, because all the anesthesiologists.
Besides Lundy, who would you mention at this time as pioneers?
Yeah, well, a little bit
Cecil
later
Gray.
on came Cecil Gray, and that in 46. And he is the one who took the balanced anesthesia concept broader and made it a triangle. And in this triangle, we had, besides hypnosis and muscle relaxation and analgesia, what he also brought already in, and he brought the word analgesia in on the moment he found that the methoxyflurane in inhalation gas was very bad to do general anesthesia. But he found out that it was a very good analgesic. It could relieve the pain. And at that time he said, why not combining methoxyflurane, because we need also to cover the pain, with the hypnosis. But the most important thing is 46, when he starts using T-tubucurin, a neuromuscular blocker. And then he said, let's combine this neuromuscular blocker.
How was it used? How did they use muscle relaxants at
Well,
the beginning?
the strange thing enough is that they use it in patient spontaneous breathing. Yeah, and this was so. T-tubucurin is not synthetically derived, so it was still coming from Brazil, brought in and then purified as much as possible, and it was not that strong working. So they were injecting it while the patient was breathing. And if you read what they were writing out, they said, "Look, we are anesthesiologists. So maybe from time to time the patient stops breathing. We should assist a little bit with a mask, and as you are a very good anesthesiologist, this shouldn't be any problem. And in a few minutes he will start breathing again, no problem."
Yeah, because the muscle relaxant, the purpose of using it was just to provide some more relaxation for the surgeon.
For the laparatomy.
It was not for intubation.
No, but the intubation was not
for
done.
mechanical.
They were breathing spontaneously. Yeah? They were still with the Omadam and the ether chloroform actually. Yeah? But he said, again, with the neuromuscular blocker, now we really can go very superficial and have no hypotension dropping out. And you need just a little bit of ether chloroform, or starting with pentotal, to have the patient just sleeping. And then he added already that analgesia. And actually he added that word without really using any drug doing that.
And were they mentioning stress already at the time of the trial?
Well, he was not mentioning that, but one of his followers, Loder, started doing anesthesia on this approach, and he said, but if we do now major surgery, I have a big problem with your approach. My patients are, and he said in that, are really under stress. So he noted that the stress was not covered at all.
57.
57, so a lot later already. And as he said, his suggestion of Loder is use the balanced anesthesia approach of Cecil Gray, but do infiltration with local anesthetics. Anesthesiologists have never done local infiltrations yet. The spinal exists already. That's another issue early, but we'll not go into spinal anesthesia with the cocaine first. And he suggested that the surgeon inject that here around the ganglion celiacus, and that means here from the right side of the stomach, and you're very, very good block. Because he said, we are not having sufficient stress suppression, do that with local regional anesthesia. And he wrote that a little bit as a reaction to Cecil Gray, who has this nice example of the balanced anesthesia, and say your balanced anesthesia is not balanced enough. You are missing one point, that is really the stress. Do some infiltration, and it might help for laparotomy. And in a reaction, Cecil Gray reacted as it was, and he reacted already in 59, but the publication came in 60. But he was a little bit afraid to do that, so he went to Ireland, and there was the inauguration of the Irish Surgical Society meeting there, nothing of anesthesia yet, and he published in the Irish Medical Journal a publication which he said, I was wrong. And he admitted he was wrong in writing the word analgesia. He said, that's not the third part. What we really need, based on what Loder has said, we need reflex depression. And then he started to little bit look at what are reflexes, how can we, and he's made a whole scheme like that. We have visceral reflexes, endocrine reflexes, skeletal motor reflexes, and there might be several, and he knows also there are narcotics you can use to do that, but there are also other approaches. And he wrote even very clearly, if I still keep using the word analgesia, people might think that they need high dose of opioids.
So we are in 1960. Were there synthetic opioids available?
Well,
already?
some opioids started coming out, but it was still very, very limited. We can say that even the morphine being already available, also subcutaneous, was used as kind of pre-medication together with atropine. And there was a long debate in the beginning of 1900s, subcutaneously, yeah, and then intramuscularly. But there was even a strong discussion between is it worth using atropine in pre-medication, is it worth to use even loads of morphine, but finally it settled down after more than 20-30 years, say less, yes, a pre-medication with a small dose of an opioid, and atropine really makes sense in preparation for surgery. And that's when then in the 60s, Paul Janssens,
so
being
tell
from
us
Belgium,
the story of
from Paul Janssens, he said, well, look, the morphines, they have very, very many effects. If I can split...
Was he a pharmacologist, a pharmacist?
He was a doctor.
He was a doctor.
He was a doctor. And his father had a pharmacy. But he said, I want to study first as a doctor.
But the company Janssen didn't exist
no,
yet.
didn't exist. But his father said, but even when you are a doctor, you should take over my pharmacy. That has a better income, and that is very efficient, and that's running very well in turnout, and so on. But he said, yeah, but I'm more interested in how these drugs works. I want to look on that. And so he came on the opioids, and he said, look, the opioids have a lot of peripheral and central effects. If I can make an opioid that is only working centrally, I might have a better analgesic. And if I make an opioid that is only working peripheral, I might do something with these side effects that are not side effects anymore. Someone with diarrhea, I can block that with a strong opioid that is having no effect centrally. And that's why he starts searching to the formula of morphine, and he was quite clever in predicting what you had to change to make it more liposoluble and go to the brains with a long, stronger effect.
What was the drug that came out?
And what came out was actually fentanyl. You see here the first report of fentanyl, and that the number R4263. And as he was, at that time, he was doing his pharmacy, so he was a doctor, but not an anesthesiologist. He didn't know that. Even anesthesiologists were very scared. The only two anesthesiologists in Belgium was the Castro and the Mundeleer in Brussels, and so each one had a new.
Wasn't the Castro French?
Was French, yeah.
Since we are among distinguished gentlemen from France,
absolutely.
I think we can make a stop to visit the French approach.
It's the French approach.
What were they doing?
Well, and each time he had a new formula, He sent it to the Castro. There was no ethical committee yet. He said, look and see and try what it's doing. Although they started first, the first experiment, the slide before, the first experiment was actually in dogs anyway. And they noted that if you inject fentanyl in dogs, they seemed to less reacting. They were still breathing a little bit. But they still feel aspect. So there wasn't, and then he started right away also in humans and seeing what the effects were. But the story is, he said this is a great drug. It's a synthetic, and it's a more less release of histamine or whatever that compared with the morphine, so that will be able to go in higher doses. He applied for a patent that he got, and he applied for an FDA approval. And that didn't work.
Why?
And well, in the American anesthesiologists, very conservative, they run what they say.
I think there's no one from
No, because they
States here.
no one. I would say we don't need any opioid to give anesthesia. And if you bring in synthetic opioids,
How did they go from that?
well,
Giving too much.
that's why you need to know your history.
Yeah.
Because now they are the ones who refuse to stop using opioids. I had last week a great
Do
discussion.
they also say that the earth is flat and
Well,
that we don't come from?
That's the problem. The belief it takes a generation before we really start. So he said, no, we don't need it. We do perfect anesthesia with ether-chloroform, and we have a little bit of morphine we inject it subcutaneous. So what was his trick? He said, well, finally he said, what if I add droperidol? And if I add droperidol, the patient will get immediately also in a state
Disconnected.
totally disconnected. So you cannot use a high dose. And so by combining, they called it in America sublimase. And your talomonal, because and so the Castro was also that drug to test it, and talonol, like a Belgian guy, I said, but what if instead of 1 ampoule I inject 10 ampoules? And he injected 10 ampoules, high dose of droperidol, high dose of fentanyl, and he invented neuroleptic anesthesia. Patients were sleeping for 3 days. But at that time, it was at least 2 weeks they were in the hospital. So that was
that abolish stress?
well, that was probably also not. But we assumed that because of that dissociation state, the patient was not really reacting mentally, but probably was reacting but was not visible at that time. So that you see how he really brought it in. We'll talk on him also a little bit later if that comes up. And so the stress was not sufficient.
But was there concern about stress-free surgery and anesthesia at the time in the 60s or not?
In the 60s, not yet. It was very limited, like Loader or whatever. But then gradually it came up, and also when they start realizing that small children, neonates, in which there was no anesthesia given, zero, just a bit local on the skin, and there was no need for that. They realized that probably we are creating problems. So they were looking like the group of the very small, the neonates, and they were looking also to the very major cases like cardiac surgery. Cardiac surgery was started up, and the problem was that this was at that time quite aggressive. It was bubble oxygenators with the extracorporeal circulation, very invasive procedures, a lot of blood transfusion. So looking for a better stress suppression was really a need at that time.
So this was the beginning of the use of high doses of opioids. Were there other situations that contributed to the large use?
Later on. And then it's the Americans themselves, but we are not in the 60s, we are then already in the 80s, who are really said, let's go to very, very high doses of opioids to cover that. Now, later on, we are already in 2000, then we get a little bit also the approach from opioids are not just only for anesthesia and not just only for oncologic end-of-life states, but patients with chronic pain, patients with acute pain that is not covered enough. We should think about having sufficient analgesics given. We put it in France, hôpital sans douleur. And it was a very good approach because many patients were laying in the hospital, even not only after the operation, with a lot of pain. No one was taking care of that. And thanks to France, we really started looking, measuring in each patient if there was pain, if it was covered. And initially, there was no need to give immediately opioids. But if you have such an approach and you make an automatic system, you always end up with opioids. And as then was said, opioids you can use also for non-oncologic, not end-of-life situations, also for chronic situations. You get an all different story.
And what was the click to start thinking about reducing opioids?
Yeah. Well, the click on thinking opioids, you might say, is actually already even, and I go back here to Diagoras in the 3rd century before Christ, when the first time they start using opium, and that was for eye surgery. He was also the first one noting that if he overdosed in the eye, the patient could have a respiratory arrest. And so he condemned the use of using opium in eye surgery. And this is real amazing. And he's really explaining all what could happen, and you should be really afraid of doing that. I also come here to Paracelsus and his contributions, because we all say Paracelsus is the one who introduced the laudanum and the alcohol opium extract. Although he was the one who was condemning it. And he even said, given the fact that I have seen that the sulfur ether is giving anesthesia and is seemingly better against the pain, we should develop this instead of developing the opium. Now, this is for a very long time ago.
So we keep going back to the
Back and
past to
forward.
go to the future.
Yeah.
It's important because it was already there, but quite often we miss
We miss
the
parts of it.
opportunity to.
Yeah, absolutely.
But
yeah.
there's a long list of side effects of opioids also.
Yeah,
right?
yeah, and terrible. And that's when really we get an enormous amount of use. Now, just before coming that, I must notice that each time an anesthesia society was established, frequently we were the experts in using opioids, in the morphine and in the synthetic one. So many of the societies, also in Belgium, we have put a papaver as the emblema, showing that's our domain, that's our expertise, and that's not for someone else. That makes us different from other disciplines. And it is true, we had all that expertise, but we should be also correct in appreciating when it's real needed and it's not needed maybe anymore, and when it's exact needed. So we shouldn't be going always higher and higher like it was, and like it was happening in the last 20 years, and we call the opioid crisis. Happening it's not because of anesthesia that this came around, but it's a little bit about the evolution of having every pain should be covered. In America, it's even the disaster that the fentanyl got also introduced inside the oral use, with a really a dramatic evolution in that.
So what's next?
And
on
the
your
side
stop?
effects of the opioids, as we always go back and forward, let's just go back to the family of Morpheus. And Morpheus is the god of the dreams. The morphine is giving dreams also. And it's striking, if you look to the whole Greece family, that they already were aware what the side effects were. You look to his 3 brothers. He had the brothers of the fake dreams, Pantasus. He had the brother of the scary dreams, Phobetor. Brother of the real dreams, Icolos. But already his mother was the god of the hallucinations, and his father was the god of the sleep. And he had an uncle, and the uncle was Thanatos, the peaceful death. You couldn't imagine the better dying with an high dose of opioids. Even his grandmother was the mother of the night, Nyx.
Well, they just missed one. The near-death experience is missing there.
So there is one god related to who is not a family of Morpheus, and that is actually Demeter or Ceres. And Ceres is the god of the agriculture and the grains. And if you look very careful, in the right hand is grain, wheat, but in the left hand, very small, is a poppy. the poppy of the papaver. Why was Ceres the god also of the poppy? And that was not because of the morphis effect, but because they were using that, the agricultures were using the poppies to make bread and oil and to eat from them. And in a very short time, it's in the Neolithic period, in the region, and it actually the wild Papaver somniferum is growing here on the coast of Italy, Spain, and France. And it's in the Neolithic period, 6000 before Christ, that the Neolithic farmers in the area of mid-Europe, also including Belgium, and more close to Tiene and Liège, that we have been cultivating for 4000 years the Papaver somniferum, and that's why the Greeks have put them there also as one of the essential parts of agriculture. But we were eating these dry, and that means there was almost no dose of morphine inside, and so not related to morphine.
Well, moving forward, at some point, our colleagues started worrying also about quality of recovery, about what happens after anesthesia and surgery.
Well, in that regard, great that Henry Kellett brought in initially the fast track. How can we get really the patients early out of the hospital? And we have here even tonight the new president of the ERA Society, so actually I should allow him to speak. He's just elected 1 week ago.
2 days ago.
2 days ago, even so fresh. Nevertheless, he was the one starting that up, Hans Kellett. And initially was a fast track, but then said it's about quality of recovery. And in that quality of recovery, he recognized also the importance of a good pain treatment. And that's why he brought in the aspect of not balanced anesthesia, but balanced analgesia. And in that means he said the balanced anesthesia is actually multimodal. Use different drugs, and in this way reduce the opioids. And that are still the recommendations I've right, multimodal analgesia to reduce your opioids as much as possible post-operative.
It's interesting. I once attended a presentation by Kellett where he showed a letter from anesthesiology refusing his first paper on this topic, but they not only refused, but advised this young researcher to choose another topic for research because there was no future there. I don't know if you're aware of that letter, but you know.
Yeah. And now if you see how it has grown out as such an important issue, so sometimes you really have, even if you have the negative reaction.
Example of what happens when you go against the tide, when you go against the establishment. You have to insist, and well, but let's move forward. What's next? So you mentioned eras, and then there's the local regional anesthesia also. You had
then we thought local regional anesthesia, is this not the real solution to get all the stress out? But what you also found was there is more than just only nerves that we have to interrupt, because if there is a trauma, you also get a dramatic release of cytokines in the circulation. And probably a nerve block alone is not enough to get that. So even patients under local regional block might still have some stress due to the humoral way, due to cytokines release in circulation. And so that's why we also said it's not just only stress, but it's only inflammation. And there seems to be a real relationship between both. Between the stress and the inflammation. So also inflammation is inducing stress. It might not be initially only pain. So that's why we say it's about stress and not just about pain that we have to cover. And we have to cover the both aspects, the metabolic stress and the inflammatory stress.
And what about the correlation between this inflammatory
Yeah.
response and the
Yeah.
autonomous nervous system?
Yeah. Well, and in that regard, the autonomic system is an important aspect, and there is a lot of, and there are many papers on that. We've not discussed these papers, but we find that the autonomic system is stimulating the inflammatory system and vice versa. And that makes it, in one side, very difficult because you block one system and still the other system activates back. But it's also an opportunity, and it means that if the inflammatory system activates the autonomic system, by measuring the autonomic system, you might also see a little bit how the inflammatory system is going, although we don't have that much sufficient data, scientific data yet to be on that regard. We had for a while a way to monitor just the stress clinically. And that's what you still do today, heart rate, blood pressure, sweating, and so on. We had also an approach with a lot of laboratory testing, and these exist already a long time. So we can measure the catecholamines, we can measure the cortisol levels, glucagon level. So we can measure many of these aspects, but they come a lot later, and it's only after, it's for pure research. And that's why also we really need for the clinical practice stress monitoring immediately, so that we can react on that. And on that there are several aspects that the autonomic system is impacting on. So we could measure the effects of the autonomic system on different organs.
And this because we cannot measure biomarkers in real time, right?
In real time,
or,
yeah.
or will there be some possibility of doing that?
That's something we are waiting. Well, several like the glucose we can measure now already online, and even that is quite interesting because
think so?
most anesthesias induce still too much stress, and we see the glucose levels rising. So by having a monitor measuring the glucose, we might be able to attenuate that in a better approach. But some of these hormones only rise quite late, like the cortisol. You see even the maximum rate after 24 hours. So that makes it even difficult intraoperative to only rely on that. Pardon me, Captain.
So this is where we have to invest on assessing the autonomic nervous system, you think?
Yeah, absolutely. And the big problem is we have the parasympathetic system and with the orthosympathetic system. And now they are always in equilibrium. And that makes it even easier that we can measure one system, and by the equilibrium we'll see what the other is doing. And it seems also that like the heart rate variability is an approach that is easier to measure the parasympathetic system, because the orthosympathetic system, we have the both effects at the same time happening. So there's a clearer view by doing a special Fourier analysis, and I will not go in detail on that aspect, but it makes it more clear to measure pure what the parasympathetic system is doing. That parasympathetic system is quite interesting, and maybe it's also something that we have to look in the future. Instead of only suppressing always the autosympathetic system, maybe stimulating the parasympathetic system would be a new approach in anesthesia to bring the balance
How
again.
can you do that?
Yeah, well, there was even electrical stimulation possibilities to do so. And we also have to look back to the fundamental, and we see also that this even parasympathetic stimulation improves here, like epithelial organ regeneration. So there are a lot of positive effects from there off, and that will be something we have to look in anesthesia in the future, not only talking about blocking, but about stimulating.
Well, and then this stress response is also present in clinical situations other than surgery and anesthesia. Like
Yes, absolutely, yeah, and that's an area. Well, maybe sometimes we have to look like in sports. In sports, they are using also measuring the autonomic system in evaluating what the reserve is. And on the opposite, we have the frail patient who has almost no reserve. They're measuring the autonomic
What about neonates?
Neonates is it a little bit the same approach actually. Even you see some even an article where we have absolutely while using actually in neonates it really makes sense. So it are the extreme situations where it can make sense to use the autonomic system measurements to evaluate how patients are doing.
Today it was interesting in a session to see that this inflammatory response happens both in patients with delirium and in patients with stress.
Yeah.
What about these monitors applied in the assessment of
Yeah.
cognition?
There was one slide that helped to a little bit understand, because even if there is inflammation, it's not always sure that these inflammatory markers will go to the blood-brain barrier. And if they go to the brain barrier, we will also get, even if the trauma is far away, you will get some brain inflammation. And that brain inflammation is probably also what is giving delirium. But the problem is that we don't know, not only have the amount of inflammation peripheral, but we have the way the blood-brain barrier is behaving. And so we might be sometimes given drugs by which the blood-brain barrier is damaged, and by which we get suddenly the delirium, and while in other patients there is a healthy blood-brain barrier and no delirium is seen. So maybe you have to focus also on the steps in between.
And when we previously talked, you mentioned also COVID patients and the stress response in COVID patients.
Yeah. And well, that was another group of patients that suddenly were quite interested. In the COVID patients, we had really the problem that it was not pneumonia, but it was really more something first started with a clotting, a thrombosis, and initially going really with an inflammatory reaction. And the more inflammatory reaction, the more severe it was. Even there was a time we were thinking we should give high dose of steroid, what was not correct either. But initially it was also, because it's an inflammation, doesn't mean also we have to give steroids to block that. But the great thing also was that with heart rate variability, you were able to measure already if the patient was in a stronger inflammatory state. Even we're thinking about, we might predict a patient having COVID even before we had these nose taps and whatever PCR testing, because on the heart rate variability you could see a lot of stress, a lot of inflammatory reaction, and so probably the patient was having already the first day of COVID infection.
Well, I'm worried that our colleagues are probably thinking that it's time to go for dinner, but it's not. It's time to go back to the future. And so, Jan, after everything, this beautiful stories you told us about, and this step backwards that we took, how do we go back to the future?
So, well, science can predict what might happen if we continue working the same way, like the ecological problem also and the rise in CO2. But science cannot predict what human will discover of nature and what he will use for new invention. And this might sometimes be quite fast, but it could take hundreds of years. So let's hope for the ecological problem that we as humans discover quite earlier approaches to handle that. And that's maybe the first message on that. That's why we should also be always positive and work to understand nature and invent new aspects to improve the problems, even the problems we created, or the problems that exist in nature. And anesthesia might be solved in the future, maybe with totally different approaches, but that again is also speculations. We should remain with our foots on the ground. And let's continue with give each patient an individual anesthesia. And I think there were also today several lectures talking about we need personalized approach. And one was showing the average dose of opioid in one group and the average dose of opioid in the other group, saying there is no difference. There is a huge difference, because in one group it was individual, and that means some patients got a high dose of opioids, the others got a very low dose of opioid, making a whole difference. If you give everyone the average dose, Well, that's a problem. Maybe we have to start looking more to the standard deviations in the publications than to the averages. And that will also, but the problem is that even if you are aware of that, it's difficult to dose exactly. And so let's say progress in anesthesiology is based on scientific knowledge, but the performance of the anesthesiologists, this will remain an art.
Right.
So thank you.
And maybe someone has some ideas to share about this before we wrap up.
First of all, a big applause for this.
Or maybe what we can do is we can share now with a beer, with a nice dish. We will share it together in an open discussion with everybody, and feel free to talk to everybody. We are here for that. And this is how we progress in the science, right? Exchanging thoughts. Thank you very much.